there is a recent press release on PSMA addition. So they see a benefit of giving Pluvicto in the castrate-sensitive setting. So there was an OS signal as well. So it could be possible down the road, Pluvicto get approved for castrate-sensitive prostate cancer. Then, radium can probably be an option later on when they truly become castration resistant. I think one caveat about combining with IB-Enza, we know there's a high fracture risk. Yeah. So if you use it, make sure patient on bone protective agents like zoledronic acid, denosumab. So that's one thing to remember. So I think so there's an interesting abstract. Dr. McKay from UCSD, she led this study, a phase 2 study, presented at ASCO this year. They look at the PARP inhibitor combination with alpha radiation, radium-223. So the interesting thing is, the benefit appear to be better for people without HR mutation. So I think, what's your thought on this study? Do you have any kind of, like inputs, or do you think this may have some potential, practice implication?
Go ahead, Ed.
It's a small study.
It's a small, it's a small study, and with the potential move of PARP earlier on, I'm not sure how much it will shape the landscape. It was interesting. The data was interesting because there was some benefit, but again, you need a larger study, phase 3 trials to change the landscape. And as you mentioned, the frontline landscape, the hormone-sensitive landscape may be changing even before that.
Right.
So it remains to be seen if PARP is going to move later rather than earlier.
Is there a underlying mechanistic value to combining the two? What was the thought process?
Yeah, so there's ongoing trial combine PARP inhibitor with Pluvicto as well. Okay. Right? You just assume there is DNA repair defect.
Right.
Then add PARP inhibitor, add radiation.
So more DNA damage.
DNA damage is very complicated.
Yeah.
So if you go to talk to the scientists working in the lab, the radiation DNA damage, double-strand DNA damage, actually repaired by the non-homologous androgen pathway. So it's not HR pathway. And then, in the clinical setting, your work practice, I have seen lots of people with BRCA mutation. They don't really get a great response to, radium-223 or Pluvicto. So we don't really see a great correlation with HR mutation versus, a radiation sensitivity. I think when the radium was first approved, I have a guy with germline BRCA mutation. The nuclear medicine doctor even concerned about the toxicity. He actually tolerated very well, but he also didn't have a great response. So I think it's just the complexity of DNA damage repair. Yeah. It's just, the other thing is we all based on the, mutation assay. So we don't really have functional assay. So you have certain mutation, we think that change the amino acid and then change the protein structure may cause a defect in repair. But we don't really have a functional assay like mismatch repair. You have the readout of microsatellite instability. That's on your NGS report. Right. So Foundation Medicine, actually, they are generating report. If you do tissue biopsy, now they add something called HRD signature. So they look at homologous combination repair deficiency signature. So that may be helpful for some of the ATM patient, CDK12, CHEK2 patients. If you carry the signature, that give you more confidence, maybe trying the PARP inhibitor.
So that's more a reflection of the functional aspect of it?
So it's more like a look at a gene expression pattern, right? So it's it's based on their risk, because all the PARP inhibitor trials, if you look at the protocol, they all use the Foundation Medicine sequencing platform. Right. So they do accumulate lots of data, so they did some research. But again, this is just something to generate. Is that useful or not? I think you just use it, then you have some idea, right? Because there's some, so that's kind of why I tend to use Foundation a little more, particularly for the tissue, because, at least right now they offer something, I think, potentially useful. I think carriers, they have this loss of heterozygosity, right? So it's That's, I think, another level above, how they translate loss of heterozygosity to homologous recombination repair deficiency. There's really no great correlation. So I think this HRD signature is probably as good as you can get nowadays, if you try to have a sense of, the functionality of, certain mutation you see on the NGS report.
So loss of heterozygosity is also a functional assay?
It's more like a look at the genomic, it's like a genomic instability.
Yeah.
So it's more like a tumor mutation burden, those kind of readout. Yeah.
Isn't there a concern with the combination of nuclear medicine therapy and PARP inhibitor for the bone marrow suppression and bone marrow toxicity?
It is.
That may limit.
Serpinazole.
Inhibitor dose in that radium-223 combination. Yeah, so I think there's always, again, when you're treating a patient, it really depends on how patient present, their performance status, how their bone marrow look like, the disease burden. There was actually a data done at Hopkins, it's a phase 2 study. They even look at the Provenge followed by radium. There appear to be a synergy. There were even, talks about doing a phase 3. So, again, for young patients, if you really want to give them a benefit doubt to give them everything you think they can benefit, radium-223 is still, they have the phase 3 level 1 evidence to prolong survival. They have low burden disease, very small rising PSA, that's kind of my go-to drug when I see patients, with rising PSA, stable scans. Even the PSA just go up to about 1. Most insurance, they will cover, Sipuleucel T. That's kind of the thing. We know the immune system got activated, still activated for at least 2 years, probably longer.
So you're still using Provenge?
Yeah, we still use Provenge. We have some multi-center clinical trials, done with, for example, MD Anderson, MSK. I can tell you, it is still being utilized in lots of those big academic centers as well. I think it's really the key part is timing. So we know it tends to work better if you start early when they don't have symptoms with minimum disease burden. So that's, they have this PSA quartile data from the initial impact study. The lower the PSA, the longer the survival benefit. So that's kind of confirmed by a large registry trial they call it PROCEED study. So I think, it's an option. It's a kind of, again, the option is limited because with prostate cancer, people tend to live longer. So you tend to kind of, plan ahead with, particularly for younger guys, like a game plan for them.